Same position. Instead of my thumbs being right on either side of the tendon here, I'm going to cross my thumbs. And then all it is you cross them and push straight back. Boom. And you see if there's any give to the PCL. We didn't really talk a lot about mechanisms of injury and all that. We can fill that in a little bit on Tuesday. But you have to listen to the history. What was the mechanism? Because a lot of false positives come out, they think this is an ACL, but it's a PCL, because what you're doing with this drawer is you're taking him from negative numbers to even. So it feels like an anterior drawer, right? Do you everybody understand that?
Yeah.
Instead of going from 0 to positive, he's going from negative to 0. So you've got to listen to what the mechanism was. I fell on it with a bent knee. Oh, okay. That tells me a ton right there, okay? So here's his anterior drawer, which is going to look positive, even though it's posterior, okay? So here I find my plateaus, and that right there is an MD. For PCL, you got to make sure you're starting at 0. So this is about 0, wouldn't you say?
Yep.
Right? And then go posterior. That is great.
It feels fun.
That's bilaterally compare, because that's what we can do as good clinicians, right? So we come over here, and you come here, and now he's at 0 right now, so, oh, he's tight as a drum. Nothing. And posterior is absolutely nothing. Relax those hamstrings. Tearing a PCL is much, much, much less common than an ACL. Tearing a PCL, the mechanism of this would be either falling on a bent knee and literally shoving your tibia posteriorly, or, picture it, sitting in a car, you rear end somebody and the dashboard catches you right there. Okay? ACLs happen with rotations and a lot of other things. A test called a Godfrey 90-90. It's on your sheet. Okay? So how did you do this?
I got hit and landed on my tibia.
On a bent knee?
Yeah.
So just exactly what we talked about. Okay, so a Godfrey 90-90 is a test where you put both feet up, and normally if you have like a chair, it works really, really well, but I'm going to have Cara be my chair. So you're just going to put both hands like this. Underneath.
excited.
Yep, you're going to be my chair. Okay, and you're going to relax all the way. Oh my God, this is great. So then you get about right here, and you look across at the tibial tubercles, and you see how this one is dipped down? Oh, give it the,
This is why we could have brought
right? And so he has to be totally relaxed,
Oh, this is cool.
right? And you see this nice tibial tubercle here, and or tuberosity, and then you see this one's just going to dip, because his tibia is sagging posteriorly because he has no PCL. You're thinking about where the foot is going, either toward midline or away from midline. So if I'm going to do a MCL test, okay, relax that a little bit. We want her to be at 2 different positions, 20 degrees and also 0 degrees. There's lots of fibers here. And some are more stressed at 20 degrees and some are more stressed at 0. So we'll do it both. So I'm going to do her first at 20 and see if she gaps at all. There it is, real nice. Feel it? And I'm going to do it again at 0. At 0, I should get no gapping. It should be tight as a drum. At 20, I might get a little gap. And let it come back every time. Okay? Kind of see it? Other side, we're going to come around this way. Relax again. 20 degrees. LCLs you can see a little bit better. Feel that? Totally relax. And then 0. So what am I actually doing? This hand is pulling midline. This hand is pushing away. So they're working in unison, just like that, or like this, depending on which side I'm on. So this one's pushing. You're going to be right on the joint line. Okay? Not up here, not down here. Right on joint line. 20 degrees. perfect little gap, 0 degrees.
So it's just opposite motion.
Just opposite motions, yeah. If you have a person with a really big leg, okay, there's a little bit of a modified you can do with this too. Here's how I do it. If I have a big football player, I'm gonna put their foot underneath here and kind of grab it with my arm, then I have 2 hands to work with, and then I do it just a little higher. Feel that? Same idea, and I can get a little better handle on it. Because you picture somebody 6'6", 250, you got a pretty big leg, right? And I'm trying to hold the leg, do the test. So this way I can just kind of come in there and I'll be like, ah. And I can feel it really, really well this way. Good? So valgus, varus.
What would it look like if someone injured?
You'd see it gap and
Okay.
feel it. Same thing as an
Okay.
ACL. You'd literally watch the gap, and the first time you get a positive one of these, it's all right, so here's how you do the McMurray. McMurray is kind of complicated. All right, here's what we do. We are reproducing that mechanism, right? So it's going to be a rotational mechanism as we're going to go through a little bit of pressure. So I'm going to take his heel, and I grab the foot from the bottom with my hand on the heel, and then I'm going to have my other hand on his joint line, okay? And then it's this game of rotation. So we kind of loosen him up a little bit. Yeah, right? Loosen that up, and then here's what we're going to do. We are going to put some valgus stress while I rotate that tibia, and then relax, and I'm going to extend him down. And if I feel a click, it's positive for a meniscus tear. Okay, so you're kind of opening up the joint space and closing down the other side. So we do it to this direction, and then we flip this, internally rotate the tibia, and then we bring that hip into an externally rotated position, and we do it again. And while I'm doing this, if you notice, I kind of have my finger right on the joint line. You're feeling for a click as well. Okay, he's smooth. So here we go again. Externally rotate the tibia, internally rotate the femur, put a little pressure on there, and a valgus force, and extend. Feel the joint lines, see if there's anything going on. And we come the other way. Internally rotate the tibia, externally rotate the femur. Got that? Put a little valgus, or a varus stress on it this time, and feel that joint line. If there's any clicking, popping, pain, that would be positive for meniscus. Cool? Test. Okay, the grind test, you put the knee at 90-90, you're trying to reproduce the symptom, right? So you're taking your hand on the calcaneus, and you're putting pressure right down through the tibia as hard as you can, really. Put a lot of pressure on it, and then you're twisting it. That would be the same thing as if he was standing, right, and had rotational stress on the joint. That's all that one is. Super easy. But to do it right, you have to have a lot of pressure going through the tibia, and then grab the tibia and twist. Internal and external rotate. You can't just do this. I don't do anything, okay? You're just moving his foot around. I remember back 40 years ago, not kidding, had a patient in the clinic. He worked in a factory, and he said, I have this knee pain. And I said, well, when does it bother you? And he said, when I do this. And this is exactly what the test is now. He stood in front of me, and I was like, oh. He grabbed a hold of the table, and he said, when I get down here, and I go like this, it kills me. I said, oh, that's a meniscus. That doesn't take much. And now it's called a Thessaly test. Look it up. YouTube it. Get down in a squat. Get down in a squat and literally twist around. It's like you're doing the twist in the old days, the dance move. And it's called a Thessaly test. Okay? Over test is just to look for, this kind of is a transition between knee and hip. We'll use it for both. So a really tight IT band can cause IT band syndrome, okay, IT band tendonitis. So lay on your left side for me and come really close to me over here. Okay, so this is just looking for tightness. We're gonna look for tightness in the hip flexors, in the hamstrings and so forth, and this is that transitional one because the IT band is attaching to where? Tubercle. And it goes over this little lateral epicondyle right here, and it's shifting back and forth. Remember we talked about that last? Okay, so you're gonna lay down flat for me. I'm gonna take his hip into extension, and I'm gonna block it here, so I don't want him externally rotating that hip. So I always get my hip right up against theirs. Extend the hip, and then you're gonna bend that knee about 20 degrees here. See the little bend in there, 23 degrees? And then just let it drop. If it has normal flexibility, it'll drop where the foot drops below the height of the table. I'd give his a slightly tight. All right? If it goes and drops down without any help, that's normal. Flip on the other side. How do we know if it's normal? We bilaterally compare. So, for him, and sometimes if you find one unilaterally tight, that's weird. So, yeah, he's a little springy. See that? Let me do somebody else really quick. Yeah. So I would give him a slightly tight, which is truly a medical thing. Tight, slightly tight. Yeah, yeah. Take come real close to me. Closer. Got it. Okay, block her hip with mine. Extend, bend a little, and drop. She drops better than he did. See that? Not as springy. She's already done. Good? So that would be a negative. She's a negative.